Welcome to Kibbe on Liberty. This week I'm speaking with Dr. Joseph Marine, a cardiologist. We're going to talk about the potential of the MAHA movement, some of the most exciting nominations for the public health agencies made by President-elect Trump, and what we need to do to make America healthy again. Check it out. Welcome to Kibbe on Liberty. Dr. Joe, how's it going?
It's going great, Matt. Thanks for having me on.
It's good to see you. We met at Stanford University, where our mutual friend, Dr. Jay Bhattacharya, had gone through all of this years of struggle to actually host at the Stanford campus an honest and open conversation about the origins of COVID and the effectiveness of lockdowns. And as a non-academic, I didn't fully appreciate what a big deal it was when they actually had the university president show up and sort of embrace this process of actually having conversations about scientific subjects. You probably understood that better than I did, that it was a big deal.
Yes, absolutely. I think it was really a signal moment in academia that we had a formal academic conference where all of these ideas were discussed in an official academic setting with the president of the university introducing everybody, where there were people on different sides of the issues that got together in the same room and could have civil conversations in an academic setting. So I recognized at the time that I saw it on Twitter actually, that it was being promoted, and said I got to be there. So I made the trip out, and it was well worth it.
Yeah. So it would mean something to you as you're both a doctor and an academic. I don't know. Are you an academic? Would you call yourself that?
Yeah,
tell people
sure
what you do and your resume and all the bona fides.
Sure. So I'm a cardiologist. I trained at UCSF Medical School, did my graduate training in the Boston area, and I've been a cardiologist for 24 years now. I practice electrophysiology, which is a branch of cardiology that deals with arrhythmias, doing catheter ablations, implanting pacemaker-like devices, and diagnosing people with arrhythmia disorders. So I spend about half of my time doing that, 2 days of EP lab a week, and some time in the clinic as well, seeing office patients. And about my other half of the time is administrative, some education, and some research in the procedure that I do. I'm also very active in my professional societies, and so I've gotten involved in advocacy, both at the state level and the national level, and that's led me to be more involved in health policy, which I think has kind of got me interested in COVID.
Yeah, so you were already involved in health policy advocacy before COVID and lockdowns.
Yes.
And that. When did you first speak up about some of the government policies in response to the emerging pandemic?
Well, I think from the outset of the lockdowns, I was very concerned that was a wrong decision. You know, I was actually in the hospital in my office when the governor of Maryland gave the order, and I still remember my sense of disbelief that this can't be happening. What do they think is going to happen if you try to shut down society, shut down the supply chain of everything? What's going to happen to medical care? So, I voiced that to the people around me in my immediate environment, and, their response was, well, this is coming down from the top of the health system, and this is, what we have to do. So, and then throughout that time, I was, active in my medical society, and I had a role in our state chapter. So I was in communication with cardiologists across the state, kind of getting their communication about how they're going to continue to take care of patients. I think that was one of my central concerns, is making sure that during this time when we were told we can't do elective procedures and many clinics closed, to making sure that patients could still get medical care. Because of course, health is not just the freedom from one virus. There's a lot of other diseases that are not going to stop. during the pandemic. So that was a big part of my focus, is making sure that patients could still get care, that patients could still get procedures when they needed cardiac procedures. So that was my immediate focus.
Did the governor of Maryland essentially lock down the hospitals the way that a lot of governors did, saying we're going to prioritize for COVID and actually make it illegal to do so-called elective surgeries?
I don't think make it illegal, but there was a clear sense that the hospital, they were concerned, and truly people didn't know what was going to happen. There were scary images, coming out of Italy. New York was starting to get very heavy caseload. So there was concern, legitimate concern around the country about what was going to happen and making sure that we're ready, that there's enough PPE, gowns and masks and so forth for the patients that need it. In retrospect, it was not needed to go nearly to that extent almost everywhere outside of New York. But nonetheless, there was a legitimate concern that we be prepared. My view is that we should have just kept doing what we're doing until the patients start showing up, and then have a plan to shift, perhaps the least acute type of care and ramp up, be able to ramp up for COVID. But, they decided to essentially, shut down most elective and non-urgent care at the directive of the state.
Yeah. And that message, I'm trying to remember the history now, but that message was also coming from federal agencies and
yes.
Deborah Birx and Anthony Fauci.
And even the medical societies. I mean, there's a statement from the American College of Surgeons about how to prioritize. Other societies, took part in that conversation as well, as how to prioritize. And again, we didn't know how long it was going to last, right? They said 2 weeks to slow the spread. So in my mind, we'll defer cases for a couple of weeks. We'll be able to manage that. And then, 2 weeks turned into 6 weeks. And I remember when cases peaked around April. It was like earlier mid-April, is that, okay, this is, they realize now, they must realize that, this isn't what they told us it's going to be. Yes, it's a serious health crisis, but it's not the existential disaster that people told. So surely they're going to start undoing some of this. And as week after week dragged by and nothing changed, I actually wrote a letter to the governor of Maryland, I think it was at the end of April, that, you're harming patient care by restricting the ability to do so-called elective procedures. You have to end this. And, a few days later he did. I don't know if other people were writing or if my letter had any impact. I like to think that maybe it did.
Yeah.
But, so that was one of the little ways that I spoke out, I think, to try to make things better.
Deborah Birx not only admits, but sort of brags in her autobiography that 2 weeks to flatten the curve was a noble lie, and that she always knew that it was going to go on much longer. Supposedly a public health official not imagining the sort of obvious, if unintended, consequences of prohibiting people from seeking care. It's a weird mindset that she wouldn't think about that, or maybe talk to people on the ground who would obviously be thinking about that.
Yeah, it's really kind of a shocking admission, because one of the most important elements of crisis communication, which we engage in medicine all the time, is that you have to tell the truth. If you have to retain your credibility with the patient, and for an official to retain credibility with the public, you have to be honest during a crisis about what you know, what you don't know. So that was a very concerning statement. And the comment that they didn't really think about the consequences is also another really shocking admission. And I think Dr. Collins made the same admission in a conversation that he had last year. As doctors, we always think about the pros and cons of anything that we recommend to a patient. It's standard medical practice.
So I just had, I guess he's Dr. Brad Wenstrup, who is also a congressman, on the show, and I was talking about what appears to me to be an undermining of local knowledge and doctors thinking about the practical logistics of how to manage patient flow and hospital beds and personalizing care for each patient. Somehow that all became a top-down central plan that was being driven by either bureaucrats, some of whom were actual doctors, but some of whom were not, but more importantly, politicians, governors, who presumably don't know anything about how to ensure patients get the care they need. When did that happen? When did it happen? Because you were talking earlier about how people were just deferring to somebody above them,
Mm-hmm.
and layers of I'll call it bureaucracy. Maybe you wouldn't, but well, this is what they've decided. I guess we have to shut down.
Yeah.
Is it so centralized?
Well, I guess it's a little bit like the 6-foot distance rule. As Dr. Fauci said, it just sort of happened, and no one really fully understands how it happened. And, hopefully with time, there's going to be some kind of after-action review to understand how these decisions were made and how they filter down to the individual actors. At my health system, there are health system leaders who are in charge of, human resources and how to deploy human resources. And so, they make the decisions, and, we pretty much have to accept that. Now, they give you a little bit of wiggle room. So they didn't completely shut down, for example, our operating rooms, our procedure rooms, but they told us that we really have to restrict it to the most urgent patients. And that does allow the physician some discretion to say, yeah, you need your procedure now. You can't wait 2, 4, 6 weeks. We also had a little discretion in keeping our clinics open. I kept my clinic open throughout the pandemic, and other people did as well, whereas others chose to switch more to telemedicine.
So if I could character your colleagues with Dr. Marty Makary, who was just a fantastic nomination to run the FDA in the next Trump administration, and I'm thinking about his book, and I want to talk more about him, but I'm thinking about his book because it seems like the general gist of his thesis is that there's a lot of intellectual sclerosis and just doing the thing that doctors do.
Yep.
Instead of critical thinking. Was that part of it too? Just like sort of groupthink and well, they're shutting down, so we have to shut down. Is it a butt covering thing? Like, well, if we don't shut down, someone might blame us for not taking more aggressive action. What's creating the groupthink?
I think it's a little bit of everything. There certainly is a little bit of obedience in medicine. It's a very hierarchical system where you go through levels of training, and you're taught to look up to and in many cases defer to the more senior person. I think, in my education, I think in many people's education, you still do learn critical thinking skills. You're taught to question the literature, to think about how to do things better. But in an emergency type situation, people tend to revert to their following orders and obedience. So I think that is a significant part of it.
Yeah. How would you reintroduce critical thinking as a primary role of a physician?
That's a great question, and I try to, in all of my conversations, I mainly teach advanced fellows who are learning, my procedural specialty, to question everything that you see in the literature, think for yourself, make your own decisions. That extends to things like questioning diagnoses. You receive a patient, they have a diagnosis, well, you should go back and look at all the data that went into that diagnosis. That's part of the critical thinking mindset that I think is just good medical care. And then further upstream, I hope we look at medical school and think about how to incorporate more courses in critical thinking. I hope that's going to happen in the next few years.
So I invited you on this show because I love your perspective on what we should be doing. And it strikes me that some of the very best news coming out of President-elect Trump's nominations fall under this umbrella that we now call Make America Healthy Again. And you would consider yourself part of that community. Is that correct?
I'm excited by the possibilities.
Yeah.
A lot of almost everything else in healthcare got put on the back burner during COVID of the last 5 years. And it's exciting to see, real opportunities for change and improvement in our health system. I think across the political spectrum, people certainly see many problems that need to be addressed. So.
Yeah, I mean, just one problem. Again, I was talking to Congressman Wenstrup about this, is not on camera, but afterwards, that the sweeping authoritarian statements made about the COVID vaccines have had the net effect of undermining the credibility of any vaccine. And they treated them as this amorphous blob, like a vaccine is a vaccine is a vaccine.
Yep.
Well, of course, the smallpox vaccine is perhaps fundamentally different. than what they were calling a vaccine during COVID. But that undermines the credibility of medical expertise. It undermines the credibility of science itself. And I can't imagine being a parent today, having lived through the last 5 years, and wondering, okay, what should I do? Is this vaccine schedule political, or is it based on sound science? And I think the answer right now is we don't know exactly. That seems to be one of the fundamental things we have to fix going into 2025.
I certainly share that concern. It raised the whole process that we saw with the COVID vaccine approval, particularly the boosters and then the series of bivalent boosters downstream, raised questions in a lot of people's minds about how vaccines are approved and then recommended. So I share that concern. I was certainly very excited by the vaccines when they came out, and I read the pivotal studies and promoted them among my colleagues. I participated in vaccine clinics when they were rolled out to the health system, vaccinated several hundred of my colleagues myself, promoted it in my society. But as the pandemic sort of wore on, and the messaging about the vaccines clearly changed in a way that didn't seem entirely honest, and more doubts were raised about the endless succession of boosters. I think it raised questions in my mind and concerningly in the general public about our entire vaccination program. And you see those questions now being raised about vaccines that previously were widely and universally accepted.
The Free Life, Portrait of an Artist is the new documentary by Free the People, the story of Cuban-born artist Carlos Luna, who fled socialism under Castro to find his free life in America. You can watch it exclusively at civil.com, CIVL.com, throughout the month of December for free at civil.com. Check it out. There were some sort of obvious questions that should have been allowed to be asked concerning natural immunity and whether or not someone that had already had COVID should get the shots. There were obvious questions about vaccinating children and young people. And the fact that those questions weren't allowed to be asked was the first time I started paying attention and said, okay, what's really going on here? Huge red flag.
The censorship was very, very concerning. And I think, again, just as anything with medical care, open and honest discussion with the patient and at the public policy level with the public is really critical to gain trust. There's no doubt that trust has been very badly damaged. That's now been documented in articles and in a variety of sources. I think physicians can kind of feel it, that we have a lot of work to do to win back the public trust, and it really has to start with honesty, frank discussion, and an end to censorship.
Yeah. Have you, you're a cardiologist, so I have to ask the question about myocarditis. Have you seen this? Have you dealt with it personally? And what's your take on what appears to be legitimate vaccine damage caused by the COVID shots?
I saw one minor case myself, a young college athlete who basically completely recovered by the time that I saw her. I heard about another that was referred into my health system, a little bit more severe, but somebody who recovered. So, I don't have a huge experience with it myself, but it clearly was an issue, and it's a little bit concerning that, there was a lot of discussion about how well it was recognized and whether it was appropriately fully investigated. And it added, I think, to some people's doubts about the COVID vaccine and other vaccines as well.
So this seems like a nice segue to RFK Jr., who what I've seen him say on vaccines does not fall into the category of anti-vaccine. And I have not studied everything he said, and maybe he has in fact been more anti-vaccine, but he's taking over HHS, and he has very ambitious plans to, I'll say it this way, and you tell me what you think he has proposed, but it seems like patient-informed consent is a big deal going forward. And that obviously was not the case with vaccine mandates. and reforming the process, the approval process. I don't know exactly what that means, but what would you anticipate that he is going to do on the vaccine front? Because that supposedly is the most controversial thing about him.
I think that's really an unknown. Some of his past statements have concerned a lot of people in the physician community. I'm a little concerned, having come through COVID and seen the way statements can be distorted and taken out of context. From my own feeling is that we should hear what he has to say at his hearing. I'm sure he's going to be asked a lot of very tough questions about what he said in the past, the opportunity to clarify them, and most importantly, to make an affirmative statement about what his agenda is going forward in a way that's positive and constructive. The goal really has to be to strengthen public confidence in the vaccine approval and recommendation system that's been damaged during COVID, and that should really be the focus.
My libertarian bones tell me that there's two sides of the coin here. One is informed consent, meaning that you don't have to take a treatment if you choose not to in consultation with your doctor. But I'm also a big fan of the right to try movement. Mm-hmm. And I'm a cancer survivor that may have, I wasn't because of the timing of my diagnosis by 5-7 years maybe, but I might have been faced with the potential opportunity of being denied a treatment that would have saved my life. And I would like for patients to be able to make that choice as well, make the choice, the informed choice to try something that perhaps doesn't have full approval, perhaps experimental, but it all comes down to patient choice, right? It all comes down to doctors and patients making decisions. When you mandate things, when you keep things off the market, you voice them onto employers. That coercion is the problem, and I don't want to throw out the baby with the bathwater when it comes to FDA reform and say, you know what, we're going to make it twice as rigorous. Mm-hmm. Now it takes 40 years to get a new medicine approved. I think that would be a catastrophe. But I'm afraid that RFK's perspective is more worried about the shoddy approval process when it came to the COVID vaccine, which clearly was. It was politically rigged from my perspective.
Well, it was certainly, rushed deliberately because we were in a perceived and actual emergency of a very serious new infection that is claiming many lives. So I kind of understood the rationale for warp speed and the accelerated approval process. I think that, it's a delicate balance. The FDA has a very, very hard job, as you've stated, in getting the right balance of having the right amount of data up front, making sure that there's an appearance and freedom from conflict of interest in the approval process and recommendation process, and then having a good surveillance process at the back end. That's really key, that we have a robust surveillance process for all therapeutics once they're approved to make sure that they are safe and stay safe. So it is a very important and delicate balance, and I think that balance really got disrupted during COVID, and somebody has to come in and right the ship. So I'm looking forward to see what Dr. Makary is going to do.
Yeah, and I want to talk more about him, but before we get off of RFK, I want to just remind people that one of the things that you weren't allowed to talk about in public during lockdowns was the correlation between severe illness and obesity. We weren't allowed to talk about the obesity crisis. Somehow that was politically incorrect, when in fact one of the best ways that you could protect yourself from severe illness in COVID was to get in shape. So it makes a lot of sense to me that RFK would focus on that stuff. He'd focus on diet, and I don't want the government to tell me what to eat, but it would be pretty cool if they stopped subsidizing the things that are really bad for us and our kids.
Yes, that was a real missed opportunity during COVID. We knew early on that the risk factors for dying from COVID were very similar from the risk factors for dying from heart disease, obesity, diabetes, poor metabolic health. And we had the attention undivided attention of the entire country, and could really have done a better job focusing on that it wasn't all about, masks and distancing and you're shutting things down. There were affirmative things that people could have done to protect themselves better, and then we would have come out of the pandemic with a healthier population instead of a less healthy population, which is what we got. So, I think the MAHA movement is certainly focused on that, and I think it's a very important focus. The trajectory that we're on as a country is a less and less healthier population, particularly our children, that no amount of spending on medical care is going to make better. So without some kind of real revolution in the way that we think about health and the orientation of our biomedical complex, I think we're really on a bad path of uncontrolled spending and worsening health.
You would see this in your practice. What do you think is driving childhood obesity?
I don't take care of children, so I have less. I have children of my own, 3 teenagers who are now in college and 1 graduated. So I think there's a lot of factors. The food supply is certainly, I remember my kids growing up, it's when you have 2 working parents, my wife is a doctor, very hard to find the time to cook healthy meals, and you reach for the stuff that the kids want, that the kids will eat. And that's not always the healthiest stuff. So I think there's many components to that. There's the food ecosystem, the compression of our times and our schedules, the time available that you have to find and buy and cook healthy food. And then there's just a more sedentary lifestyle, more time in front of screens and less time on the playing field and being outside and being active. So I think it's multiple factors that have to be addressed. It's not just the food, but the food is a component of it.
So you're saying locking kids in their homes for months on end during COVID was maybe not the right strategy?
It was certainly not the right strategy. We really should have focused on the well-being of our young people. That was very disappointing to me, and I think, says something not so good about our society that they weren't front and center of our consideration.
Yeah. So tell us about your colleagues and friends with Dr. Makary, what's the right word? The nominee, not the appointment, but the nominee, because he has to get through Senate confirmation for the FDA. Tell us about him. How have you worked with him? And you obviously think he's a good choice. Why is he a good choice?
Well, he has so many qualifications. He's a widely admired surgeon in his field of pancreatic surgery, and he's done a great deal of important research and work in health policy, starting with his book on medical errors and then his book about healthcare pricing and the lack of accountability and opacity of healthcare pricing and how it produces all kinds of distortions in the market and really unfortunate outcomes for patients, particularly those who are less well off. So he certainly had my attention with those books. He's also talked to us about trying to improve value in care. I remember he gave a little talk to our cardiology group about thinking about things that we could do in our daily practice that would reduce the cost of the care of the patients that we take without harming quality. So he's been involved in this for quite a long time before COVID. And then we're seeing him, in the media during COVID, taking, I think, very important stances, unpopular stances, but stances that align very well with the way I saw the pandemic. I think was, many people admire him for that. So I think he's got so many important qualifications that he brings to the table. He's really the right person for the job.
He had I'm sure not for the first time, he had a fairly epic rant about masking children at the Stanford conference. And there was a time when you weren't allowed to say that. And then he just let it rip. I'm guessing he let it rip at the time, too.
It's hard to believe. I think there is a lot of pent-up frustration in those of us who went through the pandemic, feeling like we couldn't express what we wanted to say, that our voices weren't being heard. So, there is some of that. But he's been very measured in the way that he speaks about COVID and about other subjects that I think also makes him very well suited to a position in leadership.
Well, he also brings receipts, so he can back up his points. So what is your take? Obviously, Jay Bhattacharya as well, and he has been nominated to run the NIH, which feels like karma somehow. given what Francis Collins and Anthony Fauci tried to do to him. What do you know about him, and what do you think his priorities will be?
So I know Jay from his presence on social media and interviews during COVID, the position that I remember his study that he actually did, the study did early on in the pandemic of looking at the seroprevalence of past COVID infection in Santa Clara County. And that made quite a lot of waves because it was one of the first indicators that the lethality of COVID might be much less than what we were being told by the World Health Organization. So that was my first impression of him. And then his Great Barrington Declaration, which I think was a very important step for many of us who felt that we were fundamentally on the wrong path with lockdowns and medical authoritarianism during COVID. Hearing that voice of somebody who was thinking like I was and like other people were is also something that I remember him very, very well for. And then, from there on out throughout the pandemic, I just felt that really admired the positions that he took, particularly advocating for children, trying to normalize their life, get the masks off them, get them back in school to normal activities. His thoughts and my thoughts aligned very well.
Regular viewers of Kibbe on Liberty already know how obsessed I have been with the pandemic industrial complex and all of the stupid, authoritarian, and downright evil things that the government did to us during COVID-19. Well, I'm proud to announce a new investigative series that looks to get to the bottom of all of that. It's called The Cover-Up, and I'm producing it in cooperation with BlazeTV. The only place you're going to see this is BlazeTV, so go to FauciCoverup.com/Kibbe and use the code FauciLied for $30 off your annual subscription. Do it now. The truth is out there. You mentioned the disregard for the well-being of children during lockdowns is one of the more obscene things that happened. And maybe it started. Maybe we can blame the teachers' unions for part of that, but it seems bizarre to me. And I wonder if you have thoughts about why we as a country, as communities, let that happen. Was it just like a mass psychosis? Were we so afraid that we just forgot everything that we know about taking care of children?
I think there were a lot of factors. There was sort of a mass psychosis that really gripped society, and the lockdowns basically started along that path. And once society, I guess, is in the grip of that kind of fear, the fear becomes pervasive. Because, of course, there was a lot of factors that kept schools closed. There was a lot of parents that were concerned about sending their kids to school and bringing back COVID and infecting them or infecting grandparents. So there was a lot of fear out there, and there was fear among the teachers. So I think that once we went down a fear-based pathway, a lot of rational decision-making got swept to the side, and you couldn't argue, well, look at what's going on in other countries where they are having school. The teachers aren't getting sick at any higher rate. The fatality rate in children is extremely low, not really much higher than seasonal influenza. So what are we doing here? We really should be balancing risks and benefits and making this decision rather than just making this pure fear-based and inertia-based decision to keep schools closed until we're told that everything is back to normal.
Yeah, Jay obviously was doing actual science, but no one seemed to want to hear that. He actually says that the most corrosive aspect of lockdowns was teaching people to teach fellow human beings as disease vectors instead of human beings. And so that probably echoes what you just said. Like, if we're afraid of our own children because they might get us sick, it's hard to function as a society if that's the driving factor.
Absolutely, that was one of the unfortunate social impacts of COVID, and it's really striking to me how different it was in San Francisco. I was a medical student in San Francisco from '88 to '94, which was the height of the AIDS epidemic there. In my medicine rotation, almost every person that I took care of on the medicine service was a young man who had advanced AIDS. And the response of the public health community was so different back then. It was just so much more humane. It was putting people at the center. The idea of thinking of people as disease vectors was not the way public health thought back then.
Yeah.
So I think one of the stories that we have to kind of learn is what really changed. How did the public health response to epidemics become so different between the time I started medical school and today? I think 9/11 probably had something to do with it, and the anthrax attacks and the involvement in, biosecurity, getting involved in public health. That's a whole story that I think needs to be investigated and told more so we understand it.
Yes, as it happens, that's one of my obsessions, and I've been digging into this with the investigative series that we're doing at Free the People called The Cover-Up. And you may know this name, Dr. Richard Ebright. Is a scientist that was there challenging Fauci, going all the way back to 2001 when Fauci became effectively the head of America's bioterrorism response strategy. And this is where Fauci became obsessed with gain of function and started financing all of these mad science experiments. In Ebright's telling of the story, every step of the way, the lab leak in Wuhan was not the first. We've had a series of nearly catastrophic accidents from this research paradigm driven by biosecurity. And every step of the way, Fauci insists that the risk is worth it. And he's published this, like he and Francis Collins very famously said, whatever the risk is, the benefits clearly outweigh the risk. But they've never actually done risk benefit assessment. So how you would make that claim is ridiculous. But that should perhaps be one of the fundamental reforms. Certainly Richard Ebright is advocating that if we're going to do something as risky as weaponizing a coronavirus, we probably need to have a very public and very drawn-out debate about whether or not the downside is worth the upside.
Absolutely. The negative externalities of this kind of research is so enormous. There has to be greater public debate and discussion about it so that the risks and benefits are fully known and, accepted or not accepted by the public.
So what else should we be talking about? So we seem to have this opportunity. I think in a lot of ways the Trump election was driven by a very lagged public response to the consequences of lockdowns. And obviously not just health consequences, but I think economic consequences. I think people have certainly noticed that their groceries are 27% more expensive than they were before this. That, if you're living on a budget, that's devastating. But from a public health perspective, make America healthy again. What do you think some of those priorities should be? And are they projects that get the government out of the way? Are there things that the government should be doing that it's not doing now? Give me some ideas.
Well, there's a lot of things that need to be done. I think first of all is engaging the public. We have kind of this paradigm that medicine is something that we do to people rather than something that we engage people with. So I think that we talk a lot about putting patients and the public at the center of health, and we have to really do more of that, because without their engagement, we're not really going to make progress. So I think that's number one. I think two is research, more research into addressing the root causes of the chronic health epidemic is extremely important. I don't have all the answers. Food is probably part of it, but there's probably other things as well. But we really have to take a holistic look at health to try to understand what is driving this epidemic, because simply coming up with more expensive therapies, which is the standard biomedical science model to approaching disease, is not doing the job, because things are going in the wrong direction with expenses rising and the health of the public not improving. And then reorienting the scientific community around health. The standard model of developing new therapeutics has been to find a chronic disease and figure out some medication that mitigates that disease, getting it approved and then marketed and so forth. And that's, I think that's important. That's particularly valuable with more acute diseases. With chronic diseases, particularly those that have a preventable component, questions are being raised about whether that's the right approach. It's certainly not going to do it in itself, and I think there has to be more focus on primordial as well as primary prevention. So it's a real opportunity, I think, for the medical community, particularly those who have been interested and have been saying this for many years, that we need to focus more on this to really get a voice and to make a big impact. I think another thing that we need to do is reorient our healthcare system more towards primary care. We are a very heavily specialist-oriented medical community in the United States, and that's been getting more and more so, particularly over the past 10 years. So I think part of this has to be figuring out how we, as a country and as a medical community, bolster our primary care physicians and providers to support them in their work, because that's really where primary prevention starts.
Why did we get away from that? What's driving specialization?
Well, I think part of it is the culture of the medical community. When you go into medical school, the specialists, you're exposed more to specialists, frankly, in most of our tertiary, quaternary care medical centers where most medical training takes place. So I think that's part of it. It's part of its payment. So you're thinking about how we compensate and reimburse physicians for the work that we do has to be part of that as well. Those are probably the two major components that are actionable.
My primary care physician would certainly talk about payment and how the system and the third-party payment system discourages primary care at the benefit of specialization. Pays better, a lot better.
There's the compensation, and there's also the burdens of care. I mean, a lot of the sort of management burdens, filling out paperwork, prior authorizations, falls upon the backs of primary care physicians. So that's another disincentive to go into the field. We really got to look about how we make the quality of life and the quality of practice better for those in our primary care community.
Thinking about the FDA and perhaps many of the other agencies as well, one of the red pills that I took, as someone that had been, as an economist, I'd been critical of the FDA approval process going back to undergraduate school because of there's something economists call regulatory capture, where the big pharmaceutical companies can afford to spend 10, 20 years, $20 million to get a copyrighted medicine through the process. Smaller guys cannot, and you end up creating a bit of a cartel created by that process, and the bureaucracy would, by definition, be risk averse because there's a political price to be paid for being wrong, but there's not really a political benefit to allowing a therapeutic that might save lives. That's all changed since I've watched this process of pharmaceutical companies lobby the government to mandate a vaccine. And then when you dig a little bit deeper, you discover that many of the doctors inside the agencies actually have some sort of intellectual property claim on the vaccine itself. And I see this intertwined mess between medical innovation and I'll say political corruption. That has to be unwound, I think, because the problem is you end up with these perversions, like all the voices were saying the vaccine is the only path forward. It's so singular in our sense that we're going to mandate it. But there might be these therapeutics that have been proven successful in many other applications. Off-label therapeutics is very much a thing in your industry, but we're going to demonize them so that everyone has to do the vaccine. That has to be financial incentives. That wasn't about medicine at all.
The appearances have certainly raised a lot of questions and raised a lot of concern in people, and that has to be considered. There's an appearance of too much influence. There's certainly an appearance of regulatory capture that the next administration has to address to restore public trust. It really comes down to public trust. Can the public trust the process? Can the public trust what doctors are saying to them about these products? And putting informed consent at the center and regulatory reform, I think, is really key to that. There's a lot of good things about what the FDA does, and as we've talked about, it's a very challenging job getting that balance right. They like to tout this story of thalidomide, that they kept thalidomide off the U.S. market and maybe saved many thousands of people from birth defects. So they have that in their minds of making sure that medicines are safe when they're approved. On the other hand, there's a lot of innovation going on, and in basic science and in the pharmaceutical industry of new products that they want to bring to the market for patients. There's a lot of patients who have illnesses that want these treatments. So, balancing, making sure that the safety is right, that they have a freedom of conflict of interest. It's all very important things to balance. So I'm hopeful that real reform is going to happen.
I've only recently learned about off-label use as an interesting, and I don't fully comprehend how this is allowed or why it's happened, but it is in fact the case that sometimes physicians are free to prescribe drugs that haven't been formally approved by the FDA for X. Is that true?
Oh yes,
Am
that's
I
right.
saying that correctly?
The regulatory, my understanding is the regulatory authority of the FDA is to regulate what manufacturers can say about their product. So it's that fine print that you see in the box of the medicine. That's what the FDA says what goes on to that product labeling. Now, doctors can use or are free to use anything that they feel is appropriate in their training, their judgment, and their experience for a given patient. So yes, doctors do have the ability to prescribe off-label, and there's many examples of where off-label use of medications is in fact standard medical practice.
Perhaps that's an avenue to explore, because it is in fact based on informed consent.
Yes, I think so, and I think that was disturbing during COVID that there was this strong reaction to doctors using certain medications. I never really understood why there was that very powerful backlash when doctors commonly use medications off-label, again according to their experience or judgment. Some of the medications in question had been widely used, were widely regarded as safe, and then all of a sudden, they're being called unsafe and dangerous. I found that a little bit strange. I was never very involved in outpatient treatment of COVID, so I don't know all of the issues involved, but it just struck me kind of as an outsider looking in. Why is there this extremely strong reaction to these doctors prescribing these off-label medications when this is something that we do all the time and are granted the discretion and the judgment to do?
I think it has something to do with emergency use authorization. If we had in fact discovered a therapeutic that showed promising results, they would have had to go through a more formal and rigorous process to approve the vaccines, and that gets to the capture and the perverse financial incentives to push forward with the vaccine, because you would want a system that looked for the best solution. I think the system produced the most lucrative solution. Now, maybe it might have been the right solution, but you could see where that would get sideways.
Yeah, I can see how that perception would develop. And if you really look at it from a 30,000 perspective, that certainly is the financial incentive of the system, as a whole, is to come up with a more expensive branded solution rather than the less expensive solution. And there's other examples of that.
Maybe I'm channeling my inner RFK right now. Sorry, Logan. I apologize for that. So, what's next for you? We started this conversation by talking about the radical notion that the Stanford, I don't know if it was the medical school or the medical center, I forget the name of the organization that sponsored that conference, but it was considered almost revolutionary that they were going to have an open scientific debate about the pros and cons of the various things that we did during the pandemic. but you told me before we went live that Johns Hopkins, where you and Dr. Markari teach, has said a very positive statement about his nomination.
Oh, yes, absolutely. That was just out yesterday, and I think there's a lot of reasons for my institution to take pride in one of our top people being nominated to such an important position.
Have you, at least until you've done this program with this crazy guy, have you gotten any professional blowback for voicing your opinions at Johns Hopkins?
A couple kind of quiet conversations of expressions of concern, nothing really major. I think Johns Hopkins overall, I have to say, is very supportive of free speech and the academic mission. They actually had another policy conference a few weeks before the Stanford policy conference where, COVID policy, was discussed openly. And I think Dr. Markari has said the same thing, that the institution overall has been supportive of him, even if his and our views are not aligned with those of some of our colleagues.
We should add this to our 2025 agenda to allow for medical innovation and debates about science to happen freely on university campuses. That's pretty radical stuff.
Well, that's what we should be.
Yeah.
That's our mission, and I hope that universities in general are realizing that if they're not the center of these kinds of challenging conversations, then what is the purpose of having universities?
So where do people find you? I know you're on X, and where can people find your public policy work specifically if that's something people are interested in?
Well, I have a few papers published, but mostly it's statements on X, Sensible Medicine. I write for this blog journal that's online. I think it's a great, it's another product of the pandemic to foster open discussion about COVID and many other topics, and so I hope to continue doing that kind of work.
Is that your blog, or is it people
Dr.
like you?
Prasad Mandrola and Dr. Sifu.
Okay.
And I think Dr. Markari was involved in the founding of it as well.
SensibleMedicine.com.
Yep, it's an online blog.
All right. Very cool. Thank you. Appreciate
Thank you.
it.
Enjoyed it.
Thanks for watching. If you liked the conversation, make sure to like the video, subscribe, and also ring the bell for notifications. And if you want to know more about Free the People, go to freethepeople.org.